All right, so today we're talking about what to do when you inherit those chronic pain patients on opioids. And so we're looking forward to that, and we'll be back to him. Are you going to share your slides today, by the way, Jordan?
Yes, yep.
Okay, perfect. Next slide.
All right, we have some great upcoming talks, but just note that on April 23rd, Kurt and I are going to be at the ASAM conference in Denver, as we expect many of you will be as well. So there will be no echo on April 23rd. And Nathan Karanda is coming up. He is a nurse practitioner with Your Path that works in mental health, and other great talks coming up as well. I'm really interested to hear more about the allocations of the opioid settlement funds by Anna. That should be a great talk and helpful for all of the listeners. And also at the bottom of the screen, there are other echoes listed. If you would like to beef up your CME, please feel free to check those out too.
Remember, free CME, she just mentioned it. Just make sure to reach out when Katie sends you that email and you finish it so you actually get your CME. And remember, we love people turning on their videos, so please feel free to do that. So Dr. Jordan here can see your beaming faces, and that just makes it so much more fun.
Just remember, we are always here for technical assistance needs. We may not answer phones at 2 a.m. or be able to help anybody with personal problems, but hey, we're here for any of those clinical cases that you want someone to talk through it with you.
All right, and again, if you want to go on the website, the core website, you can get all kinds of stuff. Don't reinvent the wheel. There's all kinds of protocols and stuff that you could find there. So feel free to look into that. All right. So with that, I didn't see whether or not that I'm having a little technical difficulty, but we'll let you introduce yourself, tell everybody a little bit what you're doing up in Hibbing, and then we'll let you get to the talk. So perfect.
Excellent.
Do you know how to go into presenter mode? There's a little thinger. If you hover over the bottom right of your screen, it looks like a little projector screen with a minus sign in it. It's next to the like zoom in and zoom out tab. If you click that, it'll make it so the audience can only see the slide you're presenting on at that moment.
The bottom right, that's my little leave button.
Ooh.
What do you now?
I was just going to say, do you see on your bottom right screen right now, it says like 105% with like a sliding bar in the bottom right of your PowerPoint screen?
Oh yeah, over there I do, yes.
And then to the left, if you move your arrow to the left, to the first screen, right there.
Yay, you did it.
There you go. Oh.
We're going?
We're going.
All right.
You might need to click display settings, at the top.
Okay.
And then swap presenter, view, and slideshow. There you go.
Perfect.
Got it. Thank you.
You're going to have to speak up just a little too. We're having just a little trouble hearing you.
Sounds good. I will do that. Is this a little bit better volume for you?
Yep, that's better.
Very good. Awesome. Well, thanks for having me. It's I've been watching these for a number of years now, and it's kind of strange and an honor to be on this side of the microphone and the screen for a while. So thanks for having me here. So wanted to touch base on inheriting chronic pain patients on the opioids. So I am at Fairview Clinic up in Hibbing, Minnesota. We have a couple of satellite clinics, one in Nashwauk, one in Mount Iron. And so overall, we're still very rural, and our provider group's about 15 to 20, kind of just depending on the time of year. So kind of came into this topic by circumstance. So we've had a number of provider turnover. We had some that have expected to retire, some that switched to just hospital, some that we've lost, as well as there's another healthcare system in the community and a couple of retirements there. And long story short, having a hard time getting new providers up and hitting. So we're kind of absorbing this huge panel of patients that have been with some of these providers for many, many years. And it was starting to cause a fair amount of angst among us providers that were taking on these heavy caseloads with really complex medication regimens. And so put together kind of some research and a talk for my partners up here on strategies for what we can utilize going forward as we're kind of inheriting these patients. So that's how this kind of topic came to be. So a couple of learning objectives. Very important, as with all parts of medicine, but especially kind of these higher emotion type visits, checking our biases. It's we're reminded of it all the time, but it's very important to always kind of take a fresh perspective. So I'll get into that a little bit. The importance of setting expectations, or having a groundwork, a template, something that you can fall back on to help keep these visits organized and keep yourself on track and consistent. So working on developing some type of framework. And then finally, at the end, I'll kind of touch on a few different resources. There's so many good ones out there, and like one you just mentioned was the Core series, and one of many good ones out there. So just reminding us of some resources that are out there. So what's been happening a lot up here is we are taking on all these, quote, new patients from former partners. And a lot of them, specifically around these chronic opioids, are coming in, and we're having these emotionally charged visits. And that's on both sides of it. These patients may have been with some of these providers for literally decades, on some of these medication regimens, chronic opioids, for many years, sometimes decades. They're nervous about what's going to change. They've just lost their consistency, that provider that knew them in and out and that they could rely on for these medications. So it's high stakes for the patient coming into it. And as we've found on the provider side, we're getting kind of bombarded with all these new patients that are on some of these heavier regimens. And so we're going into it with our hair on, and we're kind of what are we going to do? How are we going to manage this? We're going into it with nervousness about, is this the best management option? We're doing our chart prep and reviewing these cases, and minute by minute, slowly, our anxiety is building on our provider side. We get more comfortable as we do that, but that was what I was kind of seeing, or as I was talking to some of my partners, is that they just were starting to dread some of these established care visits because it would turn into these high emotional cases. So kind of going into it, being aware that, yep, this is an emotional type of transition for those patients. And this is kind of the first time I'll mention it here, is step one of checking our biases. And that's something that we've been hammered home throughout our education, throughout our careers, and seems like common sense. And I think in general, if we ask around, we probably all feel like, yeah, I think I do a pretty good job of recognizing my biases and trying to put those aside. And but the reality is, as we're doing these chart reviews and getting these new patients, we all have these biases. We can't help it. That's how that's part of our life, our experiences that we've put together. And so checking those each and every visit, whether it's purposeful before you knock on that door and walk in, or while you're doing that chart prepping to say, this is a new patient, new experience, we're going to start fresh. These first time encounters with them, a lot of the times they're taking on not just their chronic pain, but their other chronic conditions, their diabetes, their blood pressure, their heart disease, and we kind of ultimately feel this kind of pressure to cover everything all at once. The reality is these are chronic conditions, including their pain and their med management. The goal, as we're taking on these patients, shouldn't be to resolve everything on day one. It's about continuing the best management plan long term. So kind of reminding ourselves, taking that pressure away. It's not going to be able to resolve everything. Okay. Sorry, we're just checking with here.
Mute you on there.
Danielle swoops in and saves the day.
Okay. Yep.
How about now? Can you hear me a little better now?
I hope it's echoing now.
It sounds way better, but we got a little echo.
So turn your volume on there all the way down.
You should just
Right.
There we go.
Now I muted my computer and my microphone. I'm going through Danielle's phone.
How's that seem to you guys?
Say a little more. Say
Can you
like,
hear me okay?
It's like
Can you
you're
hear me okay?
tuned off.
Can you hear me okay or not really?
it's a little quiet. Are
But
you
that-
able to like hold the phone closer to you maybe?
Sure. Yeah, of course.
Talk into the phone.
Yep.
How about now?
Can you hear me better now?
Way better.
That's good.
Now we're rolling again? Okay. Sorry about that.
That's okay.
All right. So back to this first visit. We're just meeting with people for the first time. Part of the goal should not be to resolve all of our issues. It's getting to know them. It's working on building our therapeutic alliance, building that trust. That's part of their anxiety is they've developed a relationship with their former providers that they've been able to trust over the years, and they can feel kind of helpless and lost. Like I had mentioned in the objectives, part of it is relying on the standard framework, which I'll get into what we've kind of talked about in our system, and what types of framework and care maps that look like. Another kind of common reminder that I wanted to share with our group when I was trying to help some of our providers through was that chronic opioids can be used appropriately. They do have a place. They do provide quality of life and functionality, and they do have a purpose. So part of what kind of the push or the pendulum has swung so far was that everybody needs to be off as soon as possible, and all opioids are always bad. But being okay and comfortable with managing them appropriately is definitely an option for a lot of these patients. And then finally, one other tip that we've been kind of trying to utilize was that separate an established care visit this first time you're meeting them from a dedicated chronic pain follow-up where you can spend the adequate time addressing that specific topic because it deserves that. I mean, this is in their minds one of the most important concerns. Spend a whole visit doing it. So first things first is just that established care visit. So when we're going into those new patient meet and greet, established care, however we want to phrase it, treat the chronic pain similar to how you're managing the other conditions. You're going through their problem list and you're getting an update of what their status is, whether it be diabetes, hypertension, thyroid disease. Similarly, go through their chronic pain and get a brief background. It's much better off to bring it up front. Talk about it. It's the elephant in the room. Acknowledge it. Bringing that up is going to avoid that increasing tension, that building anxiety. A lot of the times, these patients might not necessarily be that engaged in what you're talking about anyways, because they're so busy worried about, well, what is going to happen with my pain meds? So bringing it up and just kind of normalizing it and providing that security for them that, you know what, I am going to be okay going forward. And then you can start having more in-depth conversations. I've been setting the stage with these new visits. I say, I'm going through your surgical history, your family history. We're going to set up a follow-up in about a month. We're going to, keep your chronic and address just your chronic pain at that time. So use this first visit as the basic med reconciliation, basic review of are their contracts up to date. But bottom line, what we've been trying to support is that, assuming that there's no red flags, normalizing it to just continue what they're on for now until you can spend your time really going through their histories with them and what options are going to be best long term. These are our former partners or retired providers or whoever it may be that felt that this was an appropriate medication for them to be on at one time. And as long as nothing's jumping out at you, continuing that inherited regimen. During this visit, some other kind of tips that I've been trying to share is to be very intentional with our phrasing. We can be sharing the same messages, but it can be received very differently depending on how we're bringing up to our patients. And this is the second time recognizing those biases, is bringing up the challenges of recognizing transitioning from providers is hard. They do you very well. First things first is let's just get to know you and put out any issues that you need right now as far as refills, and long term we'll continue a best plan for this chronic condition. It's subtle things like, for example, offering Narcan. Kind of dual purpose here. You're doing it to build trust, to demonstrate, what, I'm looking out for your best interest. I want to take safety into mind, and it also kind of underlies the risks of, hey, this is chronic opioid. If this, not necessarily the patient, but if this could get into the wrong hands, could have potentially fatal consequences. So you're kind of building that therapeutic alliance and also setting the stage that it does come with risk factors. So it's all these kind of little phrases, little nuances that can try to incorporate into these first visits to help build that foundation, so that down the road, if and when you do want to talk about weaning, if needed, that they can find some comfort and trust in your recommendations. With this initial visit, it's kind of getting some of that housekeeping in line. Have they been seeing other pain specialists? Are there orthopedic teams involved? Do you need to request outside records? So when you do the chronic pain visit a month down the road or whatever it may be, that you're going to have all your ducks in a row so that you can have a really productive visit. So complete your first kind of established care with these new patients, schedule a follow-up right then and there. All right, now let's do a chronic pain visit, and that's where you can spend your time getting into more of the details of that. Also dual purpose. By scheduling a dedicated chronic pain visit, it shows the importance that you place on this issue and this med management. It also is kind of now early on setting the stage that, yep, there will be expectations, there will be some structure that we're going to follow to safely utilize these medications. So kind of this first visit, it's all about setting the stage and expectations while trying to build that therapeutic alliance or that trust. Ideally. I know these are all in an ideal situation, but those are the goals of our visits, and that's really challenging. It takes time. It's hard work to do this up front, but in the long run, that is going to hopefully provide more beneficial relationships between you and these new patients that honestly are stuck in really challenging situations. Okay, so you've done your established care visit. It's been a month or 3 months later, or whatever it may be, and you haven't returned for that dedicated chronic pain visit. So this is where you can spend time digging into it, more of a problem-focused visit. What is their pain sources? How long has it been going on? What management options have been utilized so far, it's a bit surprising, I guess I would say. Sometimes we've been inheriting patients that have been on chronic opioids for years, which has been the norm, as we know, going back in decades past. And a lot of these patients maybe haven't had any updated imaging, therapy, injection, any other kind of ancillary or supportive options. And maybe that's because they've tried them in the past and didn't find them really helpful. But trying to get yourself up to date with what's been done lately is going to help set the stage for what we can offer going forward as we're kind of resetting our management plan. So getting that history really important. I use this kind of visit to help, again, kind of extend that expectation setting. Are you going to do every 3-month visits? Or are you going to do 6 months, whatever your timeline might be? Be upfront and be purposeful with explaining kind of what the expectations are. Is going to save both you and on the patient side. They know what to expect. And on your side, you kind of know what you're expecting out of the patients. What's your urine drug screening policy? What's your refill policy going to be? Hopefully some of that's included in your chronic opioid contract. But this is one of the times to kind of clearly state that they're transitioning between providers, and you can get on the same page there. This is where you can start the initial conversation of bringing up tapering. And part of that is it necessary? Have they been on this regimen for 10 years and nothing's ever changed? And they've been compliant throughout, and there's no escalating doses, and they're working and it's providing quality of life. Do they need to taper? And if so, continue as we can safely. But long term, in general, we should always at least be bringing up tapering annually with that goal of, are we always using the lowest or the minimum effective dose? We always want to use the least amount that we can. That's one of the phrases that I've been utilizing with our patients. A lot of these times they've ended up on scheduled opioids, and maybe that's what they need in their lifestyle. But one thing that I bring up with them is, are we using the least amount that provides the quality of life that we're looking for? So this is where that preliminary tapering discussion comes up. Another key point of my initial chronic visit, chronic pain follow-up, is kind of now, so I touched on identifying our biases. Now another one of the kind of the more challenging but important social aspects of medicine is motivational interviewing. What prevents them from weaning, or what prevents them from using less opioids, or kind of putting that question back on them, reflecting instead of just digging into, conflict, I guess, for lack of a better word, of they want more, we want less. Well, what is getting in the way of that? So what are the challenges from weaning? Have they tried weaning? Have they experienced withdrawals before? Getting more background information on what the process will look like going forward. One other key point that I was going to bring up, or that I do bring up with my initial chronic pain visit, is polypharmacy and the risks that are involved there. A lot of these patients that I'm sure many of us have seen before is that they're on a variety of different medications, including often other controlled substances. Getting a background why they're on these other controlled substances, it's been a bit eye-opening as I'm doing some of these med reconciliations. How frequent patients might not necessarily know the indication exactly, or their perspective of why they're on it might be different than what their previous providers might be. And so going through that med list, and particularly the controlled substances, and kind of clearly stating, here's one of the concerns with some of these chronic regimens is that there is some overlapping risk. part of addressing their chronic pain and getting back to tapering it if it's necessary is being upfront and addressing the root of why we're on these medications to start with, or why we're on any treatment, really. And if you think about it, it's about extending quality of life, functionality, and for some, and not necessarily opioids, but for treatments in general, extending longevity. When we're using chronic opioids, or when they've been used in the past, that those same goals are in mind. Is it providing more benefit from quality of life and their ability to participate in ADLs or whatever it may be? Do we get more benefit in those categories compared to if we didn't have these medications? Trying to find that balance and explaining that the goal is not necessarily to always be pain-free, but to optimize our quality of life and our function. And with that in mind, that's where that conversation can be, and reassurance I've been giving to some of my partners is that chronic opioids are okay. They have a role there. They do provide quality of life in situations other than just palliative or some of those other kind of more common scenarios. These patients that have maybe been on it for decades and now are, extremely dependent on it, but have used appropriately, they do provide improved quality of life. So having that conversation so you and the patient are on the same page about why we're using it, and setting the expectation that it might not necessarily mean being pain-free. Throughout this visit, you're also going to be kind of monitoring for that fine line between substance use disorder and appropriate chronic opioid dependence. And I'll get into that briefly here in a few slides. It's important to kind of be clear on the expectations, what the patient's responsibility is and what your responsibility is going forward here. Find your own kind of strategy that helps, whether it's putting it in patient instructions, whether it's writing it out on paper for them, putting it in my chart. Something can be simple as, I want you to, attend the physical therapy appointment that we've discussed for this appointment, to keep using this safely. And fine line there of making sure we're not being manipulative, but also that we need to be optimizing all methods that we can and using this medication safely to continue it. And so giving those expectations for the patients so they know what the plan will be going forward, especially if it's different than what their previous provider was kind of following. This is also a time to reiterate the components of whatever your controlled substance agreement might be, and whatever your policies might be. And there's not necessarily a right or a wrong, but sticking with something consistently, whether it be regarding the early refills, medications are lost, variety of different situations, kind of establishing what the expectations will be. Sometimes these conversations can get a little bit heated, and that gets back to the conversation about how we say things matters just as much as what we're saying. As I was kind of doing some research for this talk initially, an interesting point came up of that, a common kind of comeback would be, I can't fill these, from a provider, whether it be because they're not comfortable with it, whether it be because it's too early, whatever it may be. Something as simple as being careful with that phrase of saying you can't fill it. Patients know that you can fill it. You have a DA, you can fill it. So it's being purposeful with, well, why am I not comfortable filling it? Kind of setting those expectations of why the concern for chronic opioids, rather than just black and white, here's what we're going to do, here's what we're not going to do. Again, working towards that therapeutic alliance. So this, taking that initial chronic pain visit a step further again, this is what we're kind of implementing up here in Hibbing is relying on more of a template or a framework that's helping our providers stay organized, stay on track, stay consistent. And that is using a pain care map, which we have built into our EMR. And I'm sure there's a variety of different options for this out there. It's not so much the details of how we're doing ours up here, but having a common protocol for your own system in the long term is going to help you be consistent, but also just efficiency alone. Some of this can all be part of the rooming process, and it helps to make sure that we're being thorough. So we have a pain care map that we're using, and I'm going to click through a couple of slides here that I was doing some teaching for our providers. That has the pain template. It helps to extract some of that data that I was talking about with that initial visit, as far as what treatments have been done, how long have they been on these medications. It also helps include the different assessments, and depending on what organization or recommendations you follow, there's a number of different clinical questionnaires or assessments that help guide us in chronic opioid use. And I have a few of them listed there, and there's another slide coming up explaining those. So utilizing some type of template or framework is going to help you in the long run as well. And one other side note, I didn't know where else to put this, but something that it can, again, a really simple tip and can be included with these initial visits is actually just updating the signature on some of these prescriptions. I'm sure many of you have seen this as well, but so often it'll be, oxycodone, 5 milligrams, 4 hours, and then they'll dispense 60 for the month, whatever it may be, where there's that mismatch between what their daily usage is and the total quantity that you want to be using for the month. Streamlining and clarifying things just like the signature on the prescription saves headaches down the road and clarity so that the patient knows what to expect as well. Or something as simple as setting your fills to 28 days so that we're not running out on weekends, needing early refills. So kind of setting yourself up for success down the road by doing some of that housekeeping up front. That can all be included with this kind of dedicated chronic pain visit. And then finally, I assume most organizations have some form of a chronic pain contract. This would be the visit where I update my chronic pain annually, go through those specific ground rules that I mentioned earlier regarding early refills, regarding lost prescriptions, and things like that. So briefly, this was an example of our chronic pain care map. It has drop downs, and the details of these we don't need to get into, but it's a template to help just demonstrate that using this structure helps for efficiency, but also thoroughness. And so this is built into our EMR. We use Epic up here. You can select acute versus chronic. Is this a new versus established patient? And it's going to drop down the according questionnaires. And I know a lot of us get tired of the note bloat, and there's too many F2 click through to get through some of these notes, but these can be utilized efficiently, and it does overall provide better quality of care and helps to remind us that are we covering everything each visit, because it is easy to kind of slip into continuing refill, and this helps to remind us to continually reassess with each visit. So bottom line with these care maps or whatever it may be, the key that I'm trying to get across here is that developing some kind of template and structure to your visits is going to help you in the long run while you're inheriting some of these chronic pain visits. Another example of these different drop downs and the questions that can come with it, at least in our EMR here, is the duration, and if based on the duration, have you seen this provider before, and then the different qualities of the pain. Then built into our EMR, and I assume others have similar, are these different assessment tools. So here are the key assessment tools that are recommended for
SOAR.
people on chronic opioids. Can you hear me still?
Lower abs. Okay, so if you're focusing on the lower part.
Hello?
Yep, we can hear you.
Oh, sorry, I started hearing someone talking through that. Okay. Here is the assessment tools that are recommended for the chronic pain patients, and how frequently they're supposed to be recommended. So when we kind of did this movement to kind of reinvent how we're inheriting these chronic pain patients and to help make our providers more comfortable, we also did some education with our nursing staff and our rooming staff, so that when they are setting up these patients for these chronic pain visits, the appropriate questionnaires or assessment tools are assigned and completed. And whether it be your PHQ-2 or your CAGE, it helps again to give us some objective way of monitoring and to make recommendations for. One of the most important assessment tools is the PEG questionnaire. Again, that's getting back to the root of why are we actually on these medications in the first place, and that's helping to look at, is it providing quality of life, is it providing increased functionality, and then also that pain control. So that is one that should be done with every visit, or at least every 3 months, depending on how you do your visits. And that's one that can be assigned to the rooming staff, so that by the time you go in to the visit, you kind of have that foundation set of how they're doing and can pick right up with your conversations that you've had before. Okay, another hot topic that kind of came up with this kind of influx of chronic pain patients that many of my partners have been inheriting. And that's how this all came up, like I mentioned in the beginning, was that we had high provider turnover from providers that have been here for many, many years and had some of the higher kind of chronic opioid regimens. And then there was kind of a lot of angst with those of us left that were kind of trying to pick up the pieces. We've had a little bit of a hard time recruiting up to Hibbing here for both the systems, and so we're kind of taking on all these patients. And so some of the initial reaction was, well, this is opioid use disorder. And they're strictly basing that on the numbers, the quantity. They're getting 120 tabs per month or whatever it may be. That equals addiction. Well, part of my kind of what I've been trying to impress upon my partners and what I've found through doing this research is that, of course, opioid use or physiologic dependence does not equal opioid use disorder. These patients absolutely are physiologically dependent on this medication, but can still be used appropriately. And in fact, many of them have been. So, at the end of the day, it's falling back to our DSM-5 and the diagnostic criteria for OUD, which many of us following the ECHO series are familiar with. And the bottom line is that there continued opioid use despite some of the known harms, whether it be social impairment, risky use habits, whatever it may be. So, that is the reality of trying to fine-tune these different patients, because some of them do walk the line of OUD versus physiologic, just appropriate use of high dose opioids. But providing that comfort that, just because they're on chronic opioids doesn't mean it is OUD, and it can still be done appropriately. This kind of one point that I've been bringing up with a lot of my patients that I've been inheriting lately is just this whole concept of physiologic dependence and does not necessarily equal addiction. And this is going back to that point I was trying to make about how we say and what we say matters. I use this conversation as an opportunity to show empathy. I say, I'm going to shoot straight with you. you're stuck in a hard situation. You're put on opioids decades ago when at the time that was what we thought was probably the best way to manage it. Over the years, we've realized it probably isn't. And now, just because you've been following doctor's orders and getting these refills, now your body is very, very dependent on it. And I say I recognize that you're stuck in this, in kind of in between these different generations of how we're using these medications. And I found that goes a long way with a lot of these patients, of just recognizing or empathizing with their physician. A lot of them now know with the different opioid pandemics and what's been in the news that chronic opioids are not ideal anymore. And so recognizing that they're stuck in between a rock and a hard place, but also that they're very, very apprehensive about weaning in some cases, can give them a little bit of comfort to at least know that you're recognizing that they're in a hard spot. Sometimes when we're inheriting these patients, it obviously leads to very difficult conversations. Sometimes there does need to be some tapering. Maybe as you're doing that chart review or you're having those initial conversations, there are features of OUD. There are red flags. Maybe it is always escalating doses, and maybe it's always early refills or whatever the concern may be. Whether it's the urine screens and a whole other conversation about how much we put into their urine drug screens. But there are situations, obviously, where opioid use does get out of hand. And so these were some strategies that we discussed if and when we need to talk about tapering for whatever reason may be. In general, there's very few reasons why we should do a rapid taper, unless it's blatant diversion and they're not even using it. In general, the guideline still is to do a very gradual taper. That's the standard of care. And I reassure the patients that I'm taking on is that, I may always be bringing up, are we using the least amount of opioids possible? And in the perfect world, we will work on weaning long-term, but I don't care if that takes months to years. I just always want to be doing what's going to be in the best interest long-term. That also provides a little bit of comfort for some of these patients. So a lot of times I'll do a step down and then stay at that same dose for 3 months maybe. We're still making progress, and it's giving them a little bit easier time for weaning if and when that is necessary. So go slow, hear them out. What other than pain, what are the patient's concerns with weaning? Is it also treating some underlying additional condition? What I've found as we've kind of taken on these new patients and kind of unmasking things a little bit, realize that, in part, we're probably using the opioids for mental pain or psychological pain, emotional pain. Is this actually, more of a dual mental health diagnosis, underlying anxiety that we've been kind of masking with opioids over the years? And if so, well, maybe the whole push for tapering is because we need to be working more with some of our mental health colleagues or SSRIs or whatever it may be. So being aware that there's probably multifactorial, just besides the classic musculoskeletal condition that these opioids were initially started for, or that the patients feel like they're taking them for, much more complicated than that. So being aware of that as you're having these kind of difficult conversations, and recognizing to the patient that it does affect their psychological health as well, as much as their kind of physical pain. Depending on the different resources that were out there, there's guidelines that, no more than 10% weaning per month if we're going to do that gradual taper. And so that's, for some of us out there, we kind of like to have some kind of concrete guidelines that we know at least we're not going to go into withdrawal symptoms, but they're still going to, patients will notice it. But if we're doing that amount over a month's time or 3 months' time or whatever it may be, that we're kind of trying to ease them in the right direction. This is specifically for our clinic, and the main reason I wanted to just include it today was to be aware of whatever your urine drug screen policy may be, and that there probably are two different options out there. One is just kind of the actual drug screen, which we should probably be more used ER emergency type situations, versus the confirmatory, where you're obviously you're checking what medications are in there a little bit more detailed. So what does your clinic or institution use, a screen versus the confirmatory? How often are you doing it? Are you doing it annually or with each visit? Having some kind of fairly standardized approach, and obviously can vary from case to case, but having some kind of standardization that both your patients and your nurses and your labs can all be kind of depend on that with these chronic pain visits. Taking that UDS a step further, what happens, one of the big pushes is, or the concerns as well, maybe these patients haven't had their urine screen in a long time, and now we do finally get one, and the results aren't expected. A lot of different, kind of philosophies about the urine drug screen and its utility out there. To try to head off some of those issues, things to include in that first visit is what other illicit substance is being used, when was the last time you used it, when was the last time you took your pain pills, being upfront that, we are going to be doing this urine drug screen if that happens to be your policy. What should I expect to be in there? Again, trying to build that transparency and that therapeutic alliance. So just a side note there about utilizing the confirmatory drug screen. A number of different kind of perspectives on there. At the end of the day, what I kind of fall back on is, and this is probably getting into the Suboxone conversation a bit more too, but we always need a confirmatory. And what I boils down to me is like, well, will the results impact our management? And so because the reality is a lot of situations, it might not. So let's not waste time or money on the confirmatory. But that's another talk for another day. A little bit of the resources now. This is what we provided again for my partners up here in Hibbing. But in our pain care map, and maybe different EMRs have a similar, we actually have these built-in hyperlinks to some of the main resources that are excellent out there that I used while I was trying to develop this kind of program for our group up here. And that's the Minnesota Department of Health, the CDC, SAMHSA, of course, the CORE, like we talked about in the beginning. There is a wealth of information out there, whether it be, more from the medical side of what's an appropriate weaning protocol or timing, all the way up to how to have some of these difficult conversations, how to develop your own phrases. I mean, that's part of what we're doing through this process is how can you get your points across to these patients in an empathetic way, where you're still conveying that, your concern for what their long-term well-being is. And as at the end of the day, does this chronic opioid or this medication or this treatment, some of that is as simple as phrasing as the chronic pain pills, chronic opioids, does this treatment, and putting it back into more medical terms to normalize that, are we still doing the most good and the least amount of harm? You're really truly getting back to the root principles there. So finding those resources that you can fall back on is important. Here's a few of the good ones. One of those good ones is the CDC. They have a ton of information out there for many of those same topics that I just mentioned, whether it be the challenging conversations or guidelines for how to taper, how to cut back, if that's going to be the recommendation. So, putting this all together, the point that I was trying to really bring home with my group up here was that chronic opioids do have a purpose. These are emotionally charged situations for the patient and the providers. At the end of the day, it's about transparency, expectation setting. Let them know what the groundwork is through these different templates and utilizing the different assessment tools to help truly
Jeremy,
give them the best care that we need. All right. And finding your resources for when you do run into those obstacles or those challenging situations or need help, because a lot of us, particularly like up in these rural settings, we don't have pain specialists available. We don't have pain clinics. There might be limited pharmacy availability. We kind of have to work on collaboratively figuring out a way to help manage these patients that have put in challenging situations. So with that, that's kind of what I was sharing with my group. I know there's a lot of different ways to inherit these chronic pain patients, but hopefully that provided a little bit of framework or thoughts for when the next time you have to establish care with someone on a challenging medication regimen.
Perfect, Jordan. You want to go ahead and stop sharing, and we'll open it up to questions. I'm happy to start the questions too, because I have this feeling, Jordan, that because you helped set this program up, that people come to you with the problems. Is that a reasonable thing to say?
Big time. In fact, it's kind of turned into, Jordan, Dr. Kaiser, he did the pain visit, instant referral. They just put him on my schedule. As much as just dealing with the problems, it's like, oh, great, he's going to deal with it for me. Okay, wait a minute. I'm trying to help, trying to set the stage on how we can all do this as a team. But yeah, so I mean, which is good because I'm just learning, figuring this out as I go, but it's brought up a lot of kind of interesting scenarios and collaborative work where I can, actually you can manage this. Here's some strategies you can use going forward. And each obviously situation is unique, but yeah, interesting.
You just a question kind of related to that. What do you do when you get somebody they've kind of reworked up a patient who's had back pain for 20 years and they have a normal scan? How do you approach that?
Yeah, really challenging. Surprisingly, it actually happens a fair amount, to be honest. Some of these patients have been on it for 10, 20, 30 years, and maybe the last time that they had their imaging 5 years ago, for example, I'm thinking of a case I just had this week. He comes in reporting this debilitating pain. It's always 10 out of 10, of course. Although he also kind of tells me that he's still out doing the firewood and fishing and doing functional things. I pull up the imaging, and I say, there's some mild degenerative changes in here, but thankfully, I don't see any bulging disc. I don't see any overt nerve impingement. I kind of try to use that as a tool of reassurance to say, you know what? I understand that this chronic pain is really impacting your daily life. With this kind of, reassuring imaging, that lets me know that I think physical therapy might be one of the best options for you. I think your spine disease isn't to the point where we need to restrict you, but rather we need to kind of make sure we're maximizing the supportive cares. I get mixed results with that, honestly, but I try to use it as a reassuring standpoint of saying, part of this is because we've been on these opioids for so long that part of it is your body doesn't necessarily know how to feel normal without them. But some of that I think is because that, I can rely on this fairly normal imaging, and each situation is a little different, but that's kind of how I've tried to utilize it.
Aaron, did you want to do some of the ones that are in the chat?
Yeah, the first one that pops up for me is Christina England asks, any other red flags that start immediate taper besides diversion? For example, greater than 90 morphine equivalents and a scheduled benzo.
Yeah. Definitely a hot topic, and that came up with us as well. We have a lot of people that are greater than 90 MME. A little bit mixed out there reviews, and honestly, I think policy-wise doesn't necessarily match guidelines or recommendations, because the reality is, that's getting back to someone functional. Are they maintaining their job? Are they, they haven't escalated doses in years and greater than 90 MME? Do they need to taper now or down the road? Maybe not, but you look at that, 90, got to cut back. So I guess the short answer is we're not using that as a reason for a hard taper. Definitely brings up the conversation of taper each visit if we are on those really high regimens, but that alone doesn't necessarily indicate, my guidelines anyways, an indication for a rapid taper. Like benzos, that's another big one up here, obviously, to her everywhere. For now, it kind of utilizing it the same way that we are with the opioids of like 2-year established care visit. As long as people are safe and functional, and there's not signs of that they're ER visits for respiratory distress and things like that, we're generally continuing until we can have a follow-up visit to specifically address it, and then we can really get into the concerns of those risk factors. But combo polypharmacy alone isn't necessarily indication for rapid taper from our standpoint. Honestly, mainly it does come down to the diversion is the big one, and to each their own. There's no right or wrong, but even if, let's say, the UDS comes back with an additional substance, if they've been upfront about it, and again, it's not putting them in a harmful situation, at least my practice isn't. That doesn't necessarily mean we need to things off as long as they're upfront and we're managing it together. And so honestly, diversion is probably one of the main reasons I would do the rapid taper.
Yeah, that and safety. I think, that's what Kurt taught me when I was learning. You always kind of frame those difficult conversations around patient safety. And another thing to look at, and when we were doing patient chart reviews, is like, are they having frequent emergency department visits or falls or any unexpected accidents, or is drinking also in the mix? And we need to think about that. So just looking at like the whole patient picture is super important, because you're so right, Dr. Kazor. It's very multifactorial, and it's never like a one size fits all situation, right? So I think looking at the whole picture of what's going on in the patient's life is super important, and safety is going to look different for everybody.
Yeah, exactly. And honestly, a lot of them actually are quite stable, to be honest. I mean, they have been on high regimens, but have been stable for a number of years, and they come to their visits and they aren't doing, I mean, there are a lot of those are out there, and that's that situation where I have a conversation of, hey, I'm sorry, you're stuck in a challenging generation gap here, a medical generation of how we utilize these medications and recognizing that. So,
yeah, here's an interesting one that I've never had happen to me. Do you ever anybody mention the Minnesota state statute regarding chronic intractable pain when you're trying to discuss a taper? Because I've never had that, but go ahead.
I don't have much on that either. I've never experienced it, but I suppose just learning things out there, right? So nothing. Yeah. I
get a primary care call and they say this patient has refused to taper, and so often I end up having a conversation with them. And again, it's about safety, but there is a statute about about some of this stuff that came about a couple of years back. And but I've never had anybody pull that one out. So interesting.
Yeah, interesting.
Have you one last question? Then we're gonna have to be done as we're at time. But have you had run into any of the patients that have been around for a while that were on methadone that you've had to deal with?
Yeah, I do. That are on it for chronic pain, and in fact, I have one right now that I've been working on, and they have their methadone and chronic hydrocodone on top of it, actually. And honestly, at least personally, and probably for a lot of us, I don't have a lot of experience with methadone as far as long-term management. And so I've had to reach out for a little bit of help on that one. This guy, again, was stuck in a challenging situation. So I did agree to continue the inherited methadone that he had been on for many years. But that is one where it's maybe with time I'll get more comfort utilizing it. But for now, I do have to reach out for help with that one. So, but
Yeah.
the same principle applied. Like, he had been stable and functional, and so I was at least comfortable continuing what he was. I certainly wasn't going to go up on it, and I need help with how to taper it, just because it's such a funky medicine. But yeah, every once in a while I get those.
Yeah, and of course, we're going to take one more here or so. Somebody wanted to know about your templates. You may want to, because you showed a couple. You have templates that you built, correct?
Yeah, yep. It's built into our EMR and Epic, and it's actually the university care map that has been kind of refined over the years here. So
Okay.
we're Fairview up here in Hibbing, so we're part of the UMN system.
All right, last question. This is definitely the last question.
Yeah.
How about transitioning to Suboxone? Somebody asks.
Yeah, all the time. That's probably that is how I kind of got started in working on this kind of situation and controlled substances and chronic pain, is that we have a wonderful care coordinator here, Danielle, that does all of our Suboxone visits. And so kind of before some of these providers even moved on for whatever reason, not uncommonly would their main provider actually have to kind of rapid taper, cut them off for whatever reason. Things were getting out of control. And so a lot of the times, then they would get referred to me and Danielle, and we'd be taking them on as new Suboxone patients. And so I think there's definitely situations where that's helpful. A lot of times, maybe not initially, but if you stick with the program, I feel like they always come out ahead in the end. Once they're on stable Suboxone, oh my gosh, symptomatically, safety-wise, I love it. It's just a really challenging conversation and process with some of these folks that have absolutely zero interest in that off the bat. And it's hard to push them down that road or encourage them if, you have been stable and it is working for you. It's hard to go down the road. But long term, I'm all about switching to Suboxone.
Yeah, perfect. Well, you gave great talk, Jordan. We loved having you. You'll have to come back again. You may have set the record for the most questions in the last 6 months. A lot of questions. So that's perfect.
Yeah, thank you so much.
I appreciate everybody. Yeah, thanks for having me, and reach out with questions. And I can get you these slides as well too, if we haven't already. So.
All right, everybody. We will not see you in a couple of weeks because of ASAM. So we'll see you after the ASAM meeting in a couple of weeks. All right, thanks.